Talk about a very specific case and use it as a way to think about some of these larger issues. And this is a case, if any of you are, many of you in the audience, not all, will have had a newborn screening, and any of you who have children or do so in the future or in the last few decades, this will be something that's of great importance to you. So what on earth are we talking about? Newborn screening is a form of population screening. There's about 145,000 babies born in Ontario every year. And all of those babies have this done, all of them. We have to take a blood sample. This image at the bottom is of taking a small sample of blood from the heel of the baby, of all the babies born, in order to find quite rare disorders that need to be treated before the symptoms appear. If you wait too long, if the symptoms manifest, it's too late. The classic case is phenylketonuria, which is an inherited inability to metabolize phenylalanine. If you find these kids before there's clinical symptoms and provide them with a change in diet, much synthetic food, then they grow up normally. If you don't find them, there's profound intellectual disability. And we've been doing this since the 1960s. But now we face enormous opportunities of expansion. And those are, of course, partially in technology. Tandem mass spectrometry is one of those. You can find PKU with a tandem mass.
Can you augment this with
it's not loud enough.
electronics? Yeah.
I can talk closer.
No, let you monitor around. Go ahead.
Super. So tandem mass, you can find PKU with an MSMS machine. And you can just find PKU. But you could use that same machine to find 70 conditions, or 100 conditions, or heaven knows what. DNA-based technology is also expanding and increasingly being used in newborn screening, and everybody's talking about the $1,000 genome. So obviously, where is this technology taking us? Technology used to be a limit on what we could detect in newborns. It is less and less the limit on what we can detect. The other opportunity, or issue in expansion, is of course parent advocacy. From the beginning of newborn screening in the 1960s, parent groups have been very involved in pushing for expansion of newborn screening. And this is something not specific to newborn screening. This is about the history of medical technology as well. Parent groups, patient groups, that get very involved and focused on their condition and want attention to it. Safe Babies Through Screening has been instrumental. Professional advocacy. I think we should never forget that specialist physicians and other clinicians who spend their entire professional careers working around certain diseases with certain families, get very, very emotionally committed, get very expert, of course, about the condition, but also very invested and committed to the importance of addressing these issues. And of course, if public labs can set up tandem mass and do screening, so can commercial labs. And we're seeing the growth of direct-to-consumer sale of newborn screening opportunities. So those pressures are everywhere. They're around the world. But we've seen very, very different responses to these expanding opportunities. And I just want to briefly talk about that because it illustrates the huge challenges that we face, I think, in addressing new medical technologies. So the UK and the US are illustrative of two quite distinct sets of responses to these expanded opportunities. On the one hand, in the UK, a very thorough review process has gone beyond the initial traditional panel of 2 conditions to an additional 3, so 5. And the US has gone much, much bigger. Canada is a microcosm of this. Ontario has followed the US lead. Quebec has many features of the UK model and more extremity. But why? I don't want to go in detail through all of this, but why is this going on? And much of what's going on are profound conflicts over what criteria are relevant to adjudicating what we can do in the face of what we should do in the face of what we can do. So the UK has stuck close to some fairly traditional approaches to thinking about criteria for population screening. And you'll remember that I said about 145,000 babies have to be screened every year. We do that to find about 100 affected babies. And about 1,500 families have to come in for confirmatory testing. After the newborn screen says there might be a problem, 1,500 families come in of that 140,000. And of that, about 100 families or so get the news that the child is affected with one of these relatively rare conditions. So in the UK, all of these 4 different questions are asked in fairly traditional ways. And in interest of full disclosure, I actually am a fan of traditional approaches to population screening. So first of all, we need to evaluate each condition on its merits. Is this condition worth screening for? What information do we look for? We need to find solid scientific evidence. We need to temper our hope and our expectations with high quality, as good as quality evidence as possible, and hopefully systematically reviewed evidence, collected systematically and appraised carefully. What benefits and harms do we attend to? We think about the classic clinical benefits and harms: mortality, morbidity. There are other benefits, but the reasons why we would select to screen for a certain condition is because of these medical, these clinical outcomes. And then, whose benefits and harms are we adjudicating? From a classic population screening perspective, we have to think not only about those 100 infants who are affected, but about the 140,000 infants who are screened, where harms can be quite mild, from the heel prick and the pain itself, or the educational intervention and any anxiety that that might cause when you tell parents about why this is being done, but also what's called the false positives, those 1,000-odd families who get the initial phone call to come in and have their baby checked, some of whom may never lose the fear and the concern that there is something wrong with their child, what's called the vulnerable child syndrome, and various other kinds of concerns that are attendant on that, alongside the harms and the benefits for the children that you're trying to find, the affected infants. And that's a classic system for evaluating population screening. So what's interesting in this debate that we're currently having about what to do with the opportunities we face is a very different set of answers to those 4 questions. And as I said, the US exemplifies this. So in terms of the first question, what unit are we looking at? Is this about the condition? Well, the US task force that made an initial set of recommendations that Ontario followed said it's not just the condition, it's the technology. If you've got a tandem mass machine and you can pick up not just PKU but 70 other conditions, then that's a reason for picking up those 70 other conditions. We should positively value that. What information? Well, yes, scientific evidence when we can have it, but many of these conditions are rare, so perhaps we should heavily weight expert opinion. What benefits and harms should we look for? Well, yes, we should look for medical benefits and harms, but we should also value some other social benefits. And chief among these are notions like the diagnostic odyssey. But what you might be telling a family is that you're telling a family that the child is affected long before the symptoms appear, and perhaps preventing what can be a prolonged and difficult process of finding out what's wrong with a child. When your child is ill, it can take months, it can take years to get a clear diagnosis in some of these cases. So even if you can't treat that child, even if you can't affect the mortality or morbidity, maybe avoiding that diagnostic oddity is worth doing, and all the life planning and decision making that you can enable with advanced knowledge, and reproductive decision making as well. And finally, whose benefits and whose harms? I think the US has really emphasized with their decision making approach that the primary concern here is clinical. It's about the affected infant and the affected infant's family. If in the UK, it's a classic screening model of decision making when you're trying to think about the entire population, the US is very focused on a more clinical model when you're attending to the affected infant and their family. So what's going on in Canada? As I said, there's a microcosm. And the debate has been going on. So these are just some of the arguments that are very much on the side of, I think, the US argument. Are we out of step in Canada? Canada lags on newborn screening. This is Save Babies Through Screening with one of these kinds of, this is now out of date, that image of the types of conditions being screened for, but these kinds of presentations of disparities in screening programs across the country. And this very important message that they're communicating to families in Canada, that families should be getting an additional screening test from a private lab to get as many conditions detected as possible. In Ontario, the Ombudsman got very involved with a criticism of Ontario's newborn screening program, calling for expansion and suggesting there was a very clear right to be impatient, suggesting that Ontario's newborn screening program was in some ways behind that of the third world in terms of the numbers, and with a clear emphasis that the number of conditions that had been screened for needed to grow further. Ontario had then announced an expansion to 19 disorders. But look, the state of Mississippi tests for 57 disorders. So hopefully we'll continue going. And here I think one of the most evocative arguments that we need to take seriously, that I think is very concerning, in flipping the decision-making model on its head by saying we're no longer, or should no longer, be making arguments about when to include a new test for a condition. We must argue about when to exclude a test from the panel, very much in parent advocates' perspective on things like newborn screening. So what's the answer here? I'd like to suggest, knowing that Dr. Levin was going to speak, that health technology assessment provides much of the answer. That we need to emphasize the scientific review of evidence, and we need to seek high-quality evidence. We need to consider something that Dr. Levin didn't talk about a great deal, the opportunity cost. It's very much in his talk. Economists have taught us something very important. They say a dollar is not a dollar. We don't need to think about a dollar as a sum of money we spend. We need to think about a dollar as a unit of sacrifice. Because if we spend it here, we do not spend it somewhere else. And that's what we mean by opportunity costs. We need to think about that. The irony about the quote about Mississippi is that as Mississippi expanded its newborn screening program, its infant mortality rate went up concurrently, in part because the money for newborn screening came from Medicaid, which meant from that fixed budget, the money for prenatal care went down, particularly for African American women in rural contexts. And we need to think, I think, about the full spectrum of benefits and harms for all of them. But it's not that simple, because I think some of the challenges that are being posed in the face of these new technological opportunities and parent advocacy are very real and need to be addressed. We are talking here sometimes about ultra-orphan diseases, not just rare, but ultra-rare, where we have to think to some extent about different standards of evidence. I don't know how far to go. I know some of you in this room will help to answer that question, but we have to give to some extent. And Ontario is working very hard on this issue now. We're also talking sometimes about ultra-expensive treatments. Some of the new conditions to be screened for, lysosomal storage conditions, they're $400,000 a year for therapy. So perhaps different standards. And on the question of an expanded notion of benefit, I don't know how to answer that one, but we need to think carefully about some of these issues like the diagnostic odyssey and how and whether and to what extent we value them as a primary outcome of something like screening. I think it's very challenging. So in conclusion, I think there are enormous opportunities, but limits have to be set. We need solid health technology assessment. We need some very carefully reasoned exceptions. And we need careful context for decision making. Another thing I think Ontario is doing very well right now on this particular front is trying to lodge newborn screening within a broader maternal and child health mandate. The Provincial Council on Maternal and Child Health has announced a new screening committee and is currently looking for new members. And my hope is that this will replace blood spot screening and the opportunities there alongside all the other things we can and need to consider doing for infants and children from a public health and preventative perspective. And finally, public engagement is necessary. And I think people can understand and come to accept limits. So thanks to all my colleagues.